everyone, and welcome to the Module 1 webinar. My name is Sarah Lefebvre, and I work at the University of Delaware in the College of Health Sciences. Today I'm presenting on behalf of Dean Kathy Matt and our team of UD faculty, as well as our partners, who are working together to develop the DCHI Healthcare Workforce and Relearning Curriculum. The curriculum team is a multidisciplinary group of faculty experts, and we're also working closely with Health Teamworks out of Colorado, and you'll hear from Nicole Diener from Health Teamworks in just a little bit. Before Nicole launches into content for this Module 1 pre-work webinar, I wanted to provide just a little bit of background on the curriculum itself for those of you who might not be completely familiar with this project. The vision for this curriculum was developed based on the goals and needs that were identified by the Delaware Center for Health Innovation, as well as the Delaware Healthcare Commission in RFP. So they worked together with stakeholders throughout the state and identified a set of competencies and capabilities that they felt like would be helpful for Delaware practice teams training on. So really, at its core, this curriculum is intended to be a statewide resource to help our current and our future workforce to be prepared for all of the changes in payment models and in our delivery system as a whole. So that your practice is probably facing a lot of competing demands from consumers, from state agencies and national standards and requirements and new payment models. And we're hoping and we believe that this curriculum will really equip leaders in your practice as well as the other practice team members with the skill sets and a common language that will be helpful as you really prepare for those changes. So look at those capabilities and competencies that DCHI had outlined as being priority items for training. We broke those into 6 core modules. So the curriculum will be delivered through 6 module sessions, and I'll talk a little bit more about the format of those sessions in just a minute. But slide, you can see the overall topics for each of those modules. So performance management, which is module 1, starts today with this pre-work webinar. The module will focus on population health management and health IT enablement. So that will really focus on using your cost and utilization data, understanding and using quality data that's coming out of your EHR, using data from our exchange, the DIN. The module focuses on team-based care coordination, so thinking about team building and team-based patient flow, managing the care of complex patients as a team. The interprofessional practice module focuses on optimizing your team roles. That also includes a specific emphasis on behavioral health integration. So the primary care practices work with their partners in the mental health and behavioral health field. Patient engagement module focuses on patient engagement from a lot of different angles. So thinking about cultural competency, thinking about engaging patients using IT, health literacy, communication and counseling skills, all of the different elements that will help you to better engage patients and families in your practice. And lastly, the 6th module, business process improvement, really focuses on preparing your practice for new payment models. So as we learn more about MACRA and the other changes that are rolling out this year and into the future, this module will really help you to be prepared for those changes and to be successful under the value-based payment models. To the core curriculum modules, we've also built in 8 additional in-person workshops. Those allow for a deep dive into a specific patient population content. So you'll see those come out as we go along, and you can opt into those workshops if you're interested in learning more about a specific patient population. So just a brief overview of the format of the curriculum. So we just talked about the 6 core modules, and each of those modules contains 3 elements. So the first element is the virtual pre-work webinar, and that's what we're in today. So you'll get a little bit of an introduction today into Module 1. You'll meet Nicole, who will be the facilitator for Module 1. And each of these pre-work webinars will also create an action item so that you've got something to start thinking about with your team members before you come to the in-person session. Try to hold these pre-work sessions over the lunch hour, and they'll typically be about an hour, so they'll hopefully be doable during a busy week for your practice. Next element is the in-person session, and this is really the heart and soul of the curriculum. So we try to do as much as we can online, but we've saved content for the in-person session that we feel like is really best delivered in that format. So the in-person training sessions will each have a couple of different components. The first is a live simulation, so using our healthcare theater team out of the university. And that really is designed to kind of show the big picture of where are we doing this, why is this topic important. And most of the day will be focused on skills-based training. So we'll have presentations by local and national experts on topics, and a lot of interactive time for you to work with your practice team as well as other practices who may be doing well in a particular area or maybe having the same challenges as you're having. So the skills-based training section will be really interactive, will get you up and moving around and really doing work during that time. So not a whole lot of just sitting there listening to speakers. So following the in-person sessions, we'll be holding community learning calls. So that's a series of webinars that will be held every other week, and you can hop on the call to speak with a facilitator, an expert on a topic, and again to engage with other practices that are working on the same area of quality improvement. One important thing to note about the in-person trainings is that those will rotate throughout the state. So again, this curriculum is meant to be a statewide resource. So we'll do our best to make it as accessible for as many of you as possible. So you only have to travel for all of the sessions, and at least every third session will be in your county and close to home. Other thing I wanted to be sure to mention, and again, you'll hear more about Health Teamworks in just a couple minutes, but I've been doing this work for a number of years, particularly through the Comprehensive Primary Care Initiative in Colorado. And one thing that's really stuck with me, Nicole has shared, is that really the most impactful part of their training has been peer sharing. So getting an opportunity to really work with other practices and share ideas, share best practices. So that's one of the things that we're really excited about and why we think those in-person sessions are so important. A couple other final notes before I pass it over to Nicole to jump into Module 1 content. You've heard me mention a couple times the idea of being involved in the curriculum with your team members. And we really can't emphasize that enough, that the training will be more impactful if you're able to come with at least another person from your practice. So it might be a practice manager, an MA, a nurse, a provider, somebody from your front desk or your billing staff. Whoever's really engaged in quality improvement in your practice, those are the people who it would be best to have at the training. So we try to encourage your colleagues to enroll if they haven't already, so that you've got somebody to come with to the training so that you can start to work on some of these items together during the training. The in-person sessions will take place every 4 months. So we'll have 6 in-person sessions, 1 for each module, and then in between the in-person sessions will be that online learning, the community learning calls, the pre-work webinar, so to keep the connection going online in between those in-person sessions. It runs through 2017 as well as 2018. It's entirely free for practices. We also anticipate being able to offer CMEs for practice members who would like to get those for participating. I think that I wanted to share with you. My last note here, the in-person session for Module 1 takes place on February 16th, and that's from 8:30 to 4:30 at the Star Campus Health Sciences Complex in Newark. If you're watching this webinar, that means that you've gotten an email from me, so feel free to reply to that email if you have any questions about upcoming events or additional questions about enrolling and participating in the curriculum. And we're looking forward to seeing everybody on February 16th. And I will pass it over to Cole to jump right into our Module 1 content.
Hi, my name is Nicole Senior. As Sarah said, I'm the Director of Training and Education at Health Teamworks. I've helped Teamworks for 8 years, and as Sarah mentioned, we've been doing practice transformation and training and workforce development for 10 years now. The curriculum I'll be delivering to you today via webinar, at the in-person training coming up in a couple of weeks, and also in the post-work session, is really based on a 3-day national training that we have here in Colorado called Performance Improvement Facilitator Training. It's a paid training, and we're trying to give that amount of information to you in the limited time we have with you. So I hope to get those that you can from it between work, the in-person, and the follow-up. As I mentioned, it would be really great for you to bring your teams to the in-person skill-based training. It's a great opportunity to set the context and the why for practice transformation. It helps the team really get invested in the change process. And also, your team will learn from each other and from other teams, as Sarah mentioned, during the training. So what we're going to do in Module 1 is in this pre-work webinar, we're going to be talking about what is an effective quality improvement team, how do you build one, and why is it so important. We're going to talk about the quality improvement overview that we'll be going through Module 1. And we'll talk about the importance of setting a global aim statement. At the in-person training, as Sarah mentioned, we'll be doing a lot of knowledge and skill building around quality improvement tools. So there'll be direct experience with you, learning a little bit about the quality improvement tool, and taking team time to facilitate together the actual use of the tool. So when you go back to practice, you feel comfortable facilitating the tool. And the community learning track topics will be around empanelment and risk stratification. If you were at the January 24th event, you heard me say multiple times, and I'll say this throughout the training, that empanelment is the most crucial foundational step to any type of practice transformation you want to do, both at the practice level and the system level, followed shortly thereafter by risk stratification. And we'll be talking a lot more about that in the community learning track afterward, and you'll hear from both experts at Health Teamworks and potentially some of our practices here in Colorado who've done work through the Comprehensive Primary Care Initiative. We'll also be doing an introduction to understanding data and utilizing data to guide improvement. That'd be a nice transitional topic to get us into the population health management and idea enablement of the next module in Module 2. Before we started with the quality improvement topics, I just wanted to share this complex change model with you. This is something that I discovered after years of working with practices, and it really evolved how I thought about practice transformation. And we shared this with practices both in Colorado, and it serves as a very nice template for thinking about how to manage the complex change of going from fee-for-service payment to value-based payment, and all the things that come in conjunction with practice transformation. So see across the top, it essentially takes 5 things to be able to manage complex change. One, vision, so where are we going? We all start swimming in the same direction. Where are we sort of swimming to in the next 5 years or so? Then skills, so when we're asking people to expand their roles and do new things, we're asking patients to have a different level of partnership with us. We may be asking our medical assistants to do care gap outreach or patient coaching. We need to be able to make sure that we have a plan for skill building within the practice, that we don't just reassign roles without doing that necessary training and support. A lot of different things to a lot of different people. By incentives here, we don't mean necessarily grandiose financial incentives. Incentives can mean simple recognition, it can mean gift cards, it can mean time off, it even mean a little bit of a bonus. But essentially, if we're not giving recognition for changes in behavior or changes in measure or the things we want people to be doing, we do not have the follow-through. When we say resources in primary care practices, we generally mean time and people, because those are both scarce resources. And when we think about resources and we think about all the things that we want to do in practice transformation, how do we know what those critical few things are that we want to focus on so that we can use our resources in the most maximized way? So starting practice transformation, we start thinking we can do everything and everyone can do new roles. Really, we have to be really specific around how many resources we have to accomplish our goals. And action planning. So one thing that we've really noticed here in Colorado when we hear from our practice managers is that not everyone really understands project management, action planning, or comfortable with Excel. Basically, any action plan that can help the practice understand what you're working on, how you're doing toward that aim, make sure that leaders are assigned and deadlines and things like that is a crucial part of practice transformation. So here you'll see that if you're missing vision, if you're to the right, there's a lot of confusion. Everybody's making changes, they're working on improvements, but they know exactly why or where they're going. And so there's not this sort of North Star that's guiding everybody forward. And if you're missing skills, there's often a lot of anxiety. So anxiety can sort of represent itself as resistance. So having people do new things, and we're giving information out in the meeting, and we want people to be excited about new roles and new activities. There's anxiety and perceived resistance because people don't necessarily have the skills to do that. They don't know what it means. Need training. So if you're seeing a lot of anxiety in your practice, it's around skill building and needed training. The line here, and we're missing incentives. So we don't necessarily incentivize or recognize the new behaviors and the new workflows and the new measure outcomes that we're getting. We'll see that will change because we'll start to think, well, maybe they don't care about that anymore. So work on, for example, a diabetes measure or a wellness measure for a while, and you're doing really well, and you decide to a new measure and you don't keep up with the old measure and still recognize outstanding performance on that, people will turn their attention to the new measure and forget about the old. So those incentives and those recognition programs are essential to keep going forward. In resources, there's a lot of frustration. So as I mentioned earlier, if we're giving people new roles and we're asking to do new things, we really need to make sure we're continually redistributing things across the team. So if we're asking the front desk to do new things, what will we take off their plate and who will do that? If we're adding things to the MA role, are we adding more MAs or are we offloading to the front desk? And it's sort of get into an annual or less than annual workflow process where you're redistributing roles and looking at what people are doing. But really that's an active process so that we know when people are over capacity and just can't keep up. Because once a role or a person gets over capacity, they get frustrated and they start disengaging. And we have an action plan that guides our most critical actions. What can happen is that we start to get frenetic and do a lot of different things that aren't organized well. And so they fall apart, where we work on something for a while and then we start working on another and we forget about the old thing. So action plan is a great central part of quality improvement, staff meetings, and everything we do to say, what are we working on, where are we, how are we doing toward those goals, and having a good process around that so we're not just false starting all the time. So this is something that doesn't naturally fit into the curriculum, but I wanted to share with you because I think it's such an essential part of practice transformation. So we'll start by talking about creating effective quality improvement teams. What we found over the last 10 years at how Teamworks is that if we don't have an active multidisciplinary team working on quality improvement, we tend to stall and not move forward. So we're going to talk to you a little bit about how to do this. So what are the characteristics of a quality improvement team? So a quality improvement team is one, empowered. And I mean, if we have a group of people that don't have the right representatives in it meeting all the time, have to spend time in between each meeting going to get permission or asking questions or being able to make change decisions, then the team gets very disengaged and movement doesn't go forward. We want enough representation from formal leadership in the quality improvement team that key decisions can be made within that team meeting so the action can happen between the next meeting. Secondly, the quality improvement team needs to use quality improvement. And by that I mean what can happen is that a well-intentioned multidisciplinary team will start getting together and they'll have a lot of good discussions, but they forget to use the core tools around quality improvement. And we do in the team, if any team meeting or staff meeting where there isn't a continual and disciplined focus on improvements that you want to make in the practice, making changes and making sure that those changes lead to improvement. Teams should comprise members from areas of the office. Now, when I say this, in some practices that have multiple providers, for example, I worked in residency practices where 90 people in practice. Clearly, we can't have every role in the office in that size of practice. But what we mean here is we need a core team that comprises all the specific areas of the office that touch the process that we're working on. In general, the very minimum of a quality improvement team can be a provider, a med assistant, a front desk person, and potentially a billing person. That might come on the team are behavioral health consultants, pharmacies, and other members of the office that don't directly touch every process. But essentially, when we're working on quality improvement, we want the essential members from the office in that team meeting, and we don't want others speaking for other people's roles. What we found with quality improvement teams is that if we have less than 5 people, we generally don't have enough for a quorum in large practices. Now, there may be those of you that are from rural practices where you have a total of 5 people in your office, and so you have 3 to 5 on your quality improvement team, and that's okay. But larger practice, and you have multiple people and roles, you want at least 5 to 8 individuals to represent the larger population out in your practice. On the other hand, if you have a very large practice, you don't have many more than 8 individuals, because then the team sort of gets unruly and there's too many personalities in the room and it's hard to move forward. So we really think the sweet spot for quality improvement teams is between 5 to 8 people. And really, a look of a quality improvement team is that it meets regularly. And regularly can mean something different for different practices. We say that the minimum that a quality improvement team should meet in a meeting setting is once a month. I twice a month. And we also have other practices that don't have much tolerance for sit-down meetings, so they huddle for a half an hour weekly to keep their action moving forward. The essential point here is we don't want to meet so irregularly that when we're doing action between meetings and we're collecting data, that we can't check in and make sure things are going well and keep the progress moving forward. So your practice to fit into your construct and what you consider a meeting to keep progress forward. Why teams for change? So I'm sure that you can all relate to the fact that, we're running around chaotic. We don't understand what everyone's doing. It leads to a lot of frustration and finger pointing between front desk thinking back office isn't things they should, MAs get frustrated with providers, and so on. This sort of disciplined time and quiet time together as a team allows you to do is help all of you understand the overall practice system. So starting to do workflows or process mapping or brainstorming and talking about the experience of each role, begin to understand the overall practice system and how it runs. And if you look at the quality pioneers, the statistics are still true today. That 94% of problems are the process and the system, and 6% are the people. And said something similar, that 85% are system problems and 15% are people. And so what this team time allows you to do is realize that this isn't about a bunch of people who don't care or aren't doing their job. It really has to do with trying to fix the system. Also increases the diversity of perspectives. So as I mentioned earlier, when you have a bunch of different roles with different data that they see during the day about what's going well and not going well, it gives you that diversity to be able to get more to the root cause of problems and be able to solve problems more comprehensively. First is shared leadership, because it empowers staff to identify and seek solutions to problems. I've rarely been in a practice where in a regular staff meeting, leadership is getting information out, and they're looking at the audience and thinking, why don't they care? Why aren't they commenting? What they have opinions? And I'm sitting there listening to leadership saying, oh, if leadership only understood what the real problems were, we can move forward. When we have an effective quality improvement team where everyone has a voice and equality in the team, that both allows the formal leadership to give over-empowerment to the staff to seek solutions to the problem and invites them to do so. And staff, likewise, in this calm, safe environment of a quality improvement team, feel empowered to seek solutions to problems rather than relying on leadership. And the improvement team supports success through momentum. If we're using data regularly, we're using quality improvement tools, we will be able to see things improve, and that will help us build momentum for the team and for the practice. As I'm sure all of you can relate to, people that they help create. And a quality improvement allows a multidisciplinary team to create solutions together which they buy into. The leadership model for quality improvement teams that we endorse at Help Teamworks is really not one led by formal leadership. And what I mean is if the provider leader and the practice manager are running the quality improvement team, it feel like a traditional staff meeting to staff that participate in the team. It's the best intended, it's on the high formal leadership and the best facilitation skills. It can end up feeling like a top-down meeting. And what we really endorse is a provider leader and a staff member leading the quality improvement team with support from the practice manager. The reason is that the provider leadership is obviously crucial to the patient-centered medical home and to the clinical aspect of the quality improvement team. And the practice manager can come in and out or be a member. But a staff member is the co-lead for the provider, gives them opportunities for professional growth. They can use their skills to build agendas and keep things organized and on track. And staff members affect many more clinical processes, even sometimes more than providers, especially in practices where you have part providers and people coming in and out regularly. So I really find that a provider leader and a staff leader, whether that's a front desk person who's really engaged, or an A or a supervisor, is really a great team to lead a quality improvement team. What this does is it balances top-down and bottom-up leadership. So you have just enough formal leadership there to help make decisions and move progress forward, but you have just enough of a level playing field in the quality improvement team for all team members to have an equal voice that helps things to move forward. I've heard when I shared on January 24th, or you might have read on your own time, Google did research on tens of thousands of data points trying to figure out some key common threads among their highest performing teams. So they looked at strengths, they looked at personalities, they looked at gender, they looked at age, they looked at multitudes of data, and eventually came up with two that describe their most high performing teams. One was that the teams had psychological safety and that they psychologically took care of each other, meaning if someone was struggling or needed support or just in general creating a safe environment, they did that. Also, the essential thing they found is that by the end of the project, every member of that team had equal participation time. And what doesn't mean is that at every meeting, everyone had 2 to 5 minutes to talk. What I mean is that each member was seen as an essential part of the team, and there were no dominant members or overly quiet members. That there's a facilitation style by which every person contributed equally throughout the life of the team. And that's a good thing to keep in mind for a quality improvement team. So now use some characteristics of high-functioning quality improvement team leaders, because you may be thinking, well, which staff should I choose or which providers? So your quality improvement team leaders should be responsive to data. They have a little bit of education around data, how to pull it, but they think data is important in quality improvement. So they generally show up on time, they come to meetings prepared, people really know that they can rely on them. They're excited about changes in the practice. They're not, quote unquote, seen as resistant or trying to slow the progress forward. Part of a facilitator of a quality improvement team is very, but the encouragement of open exchange of ideas. So they don't always have to be the expert. They can really listen to people's perspectives. Action-oriented and organized. So they come to meetings with the agendas, they follow up and send out information, they follow through with their own action items. Communicator. So really they can talk to providers, they can talk to staff, they can talk to patients. They're sort of a well-rounded, respected member of the team. This is really important, and I learned this lesson very early in 2009 when working with residencies. We had the brilliant idea that staff members and resident champions could lead quality improvement, and what better way to teach residents than to have them be quality improvement team leaders and then go out in the community and be able to do that. That was really great until that resident went on rotation for a month and the quality improvement team sort of fell apart. So when you're thinking about your staff members and your providers, you want to be thinking about generally full-time or near full-time and available and visible in the practice on a regular basis. And they respect it. I'll think about those staff members that are not in formal leadership positions necessarily, but who everyone goes to for advice or help with their jobs and like that. So be thinking about the most respected people of your team. So have tools for effective quality improvement team meetings. And as you'll see here, it says 5, but there's actually 6, so I apologize for that. One agenda in advance. So in general, we like for agendas to go out about 3 days in advance so people can have reminders of action items they may have had, review the notes from the last meeting. 3 essential parts of an agenda, and you will receive an agenda template from once you sign up for the training that we use at Health Teamwork. This is a follow-up on last meeting action items. There's nothing worse than setting items in between meetings and have people doing activities and then forgetting to follow up. A quality improvement team is not a quality improvement team meeting unless you set action items at the end of the agenda. If you're just having discussions and talking about problems and having really great philosophical discussions, but you're not moving change forward, it's not a quality improvement team meeting. So the front item is always follow up on action items from last meeting. And then, to the Google research and what we know, there should be plenty of time for discussion on what happened in the last meeting and where to go forward and giving everyone enough opportunity to share. And then the agenda item, as you may guess, would be set the next action item. So a still part of a quality improvement team meeting is action forward. We don't want to just do action items, quick report out, and next action items. We want plenty of time to discuss things, work it through, but at the very end, the last item is action items. We let the timekeeper be the same person. They can sort of keep progress going through the agenda, making sure you get to the action items at the end. And by taker, we don't mean sort of what we think about from formal historical hospital days where we take minutes. This is a summary of the meeting and next week's action items so that you can send it around to the quality improvement team and you can send it out to the practice so they know what you're working on. Essential thing to do from the very beginning. So again, according to Google research and what we know is that if we don't create a psychologically safe environment for our teams, it will not be high performing. So have people call people by name, having ineffective conflict, name calling, not being present, being on their phones and their computers, we won't have effective team meetings. So from the very beginning, as a facilitator, we ask that you set ground rules with your team. That also, in times of conflict, go back to the ground rules to remind people, and it's just a great facilitation tool to take away from individual behavior and really focus on the group. I have time for discussion, innovation, and assigned action items. Finally, I know I've said this before, and I'll say it again. An essential active and effective quality improvement team is one that uses regular and disciplined use of quality improvement tools. Not just process mapping once a year, they're not just brainstorming once a year, they're regularly using quality improvement teams to keep the action moving forward. And if we were in person, I'd make you raise your hand to ask you if you've been a poorly run meeting, and I know we all have been. So why is the quality improvement team so important that it be well run? Well, most buy-in from the very beginning. If you start showing up for the quality improvement team and it ends up just being a lecture, or there's not an agenda, people don't know why they're there, or they're repeating conversations in every meeting, people start disengaging. And so you want the teams to be promoting buy-in from the very beginning. And from providers, you're time pressured. So this is precious time away from the chaos to get to know each other better, work on the system, make improvements. So no one wants to be thinking about all the things they should be doing on their list. And that's what we all start doing when we're in ineffective meetings. So running an effective meeting that's just long enough to get us through our agenda, people just spending that time thinking about all the things they should be doing. So when we work on low fruit from the very beginning and things that we can really build early successes on, we start building momentum. So one of the suggestions we have is noting on something really big or out of your control, maybe at the system level at the beginning. Think about what are those pain points that can be quick wins. The team can start really building that momentum. So this is a section that's really best to do in person. And so I'm going to do my best in the in-person training to try to integrate these tools into what we do together. But there's some key facilitation tools that, when done right, can engage your team from the very beginning and equalize the environment of the team and start taking it away from the idea that there's formal leadership and staff, and really start making you feel like a team. The brainstorming. And so brainstorming is just a crucial way to get a team working together. So start thinking about what do we want to work on, or maybe you have something from the system that system says you have to work on. How do you brainstorm together about how to improve that? And so there are key aspects, and I know we've all been through brainstorming before, but if done poorly, this can start disengaging the team, whereas when done well, it'll start engaging the team from the very beginning. So this really, don't criticize other people's ideas. We don't want to, even if there's sort of a crazy idea and a person is on our team that doesn't sort of fit the norm with their ideas, they're still going to feel heard and engaged when they give that idea. So we really want to open and have an exchange of ideas. We have people's ideas. So if we hear others' ideas and it makes us think of something, we definitely want to allow that time to build on each other's ideas. So in brainstorming, unlike in a lot of other areas of practice transformation, we really want to be thinking about quantity over quality. So we don't have to start with the best ideas. We start with the most ideas, and we're grouping those together to come up with the most effective ideas. And the more creative ideas, the better. So here we want to be thinking outside the box. So if they haven't been working, we want to keep doing the same thing. And I know the definition of insanity is doing the same thing over and over again and getting the same result. So how can we be creative? So there's brainstorm, and I hope in the in-person training I'll be able to show you those. But one, you can stay up at a whiteboard or an easel and just ask for people's ideas. And you list those out an idea, and you can group those ideas together on your list. The really engaging way to brainstorm is called affinity diagramming. It's a fancy way of saying use stickies for your brainstorm instead of a list. And so give sticky notes to all of your team members and you ask them to put one idea per sticky, go up and put it on the wall. And once you have all the ideas, you stand up as a team and you group those ideas into like topics. So just like you would have done in the list form whiteboard, this is a more engaging way of getting your team members to stand up, put their ideas up, and group them together like ideas. So it advances the engagement opportunity, listing it out as a facilitator. Brainstorm ideas. It's good to briefly discuss them, as I said, combine the similar topics, make sure you add or subtract topics as like, and then really you want to check for consensus on what you should do first. Sometimes you have a high-functioning team, not a lot of conflict, there isn't a dominant member. You really get a sense as you're discussing things and you're combining topics of what to go first. If you're a team that's sort of starting off in the storming stage and you're worried about a dominant member or a formal leader who tends to take control even with their best intentions, there's a different type of way of getting to consensus, and there's different ways of voting. So in here, if you have a high-functioning team, you don't have concerns about power differentials or anything like that, you can check for consensus and move forward. In here, if there's not consensus or you have issues with really wanting to equalize the team, then you should move toward voting. Ways to vote. So a very high conflict team that starts out on a rough patch, we really prefer to do something like a secret ballot. That doesn't have to be a box or anything like it's showing here. It can be just little sheets of paper and people put their preferred method on it and the facilitator takes those and you read them out and go towards the majority. Voting for teams that are working well together and just sort of want to vote because you can't come to consensus, there's something very psychologically satisfying about doing these two ways of voting for team members. What is voting? So you've got a large number of ideas and people to be able to vote on those is to give everyone a certain number of check marks with a marker or a certain number of sticker votes. So let's say you've got 6 ideas and you want to give everyone 2 votes. They stand up physically. They don't tell the facilitator, but they stand up and they go up and they physically mark the top 2 votes. They can give their 2 votes to one topic or they can give 1 vote to each to 2 topics. Especially, this is really great for the introverted members of your team, or if you feel like people are just going to defer to formal leadership. That gives them empowerment to stand up and actually mark their vote down with people watching them or having to hear them say it verbally. So there's something very great and engaging about that. I think equally satisfying about this next type of voting is the thumbs. Thumb up generally means I'm in total support of the idea. Thumb sideways means I can live with it, and thumb down means I don't want to do it. And so what I like about this is that the thumb middle can say, well, I'm not for or against it, but I think I could live with it. And when we're getting feedback with just thumbs up and thumbs down, there may be more hesitation than the room will say, and they'll give it a thumbs up, even though they're really a thumb sideways. So this gives really good data for a facilitator. And finally, a raise of hands works perfectly well as well. Quality improvement team done. And very well over the last 10 years in primary care and even longer, and for the foreseeable future, things are not going to be totally clear and all writing is not on the wall. So things are going to continue to change. So, essentially, you can think about a quality improvement team making progress when they reach their goal or aim statement, identify a best practice or better workflow, when it is really supporting your outcomes and you have stable data, or improvement is implemented and can be sustained. But things change and things tend to go up and down. So really the focus of the quality improvement team, maybe even the team itself may change, but quality improvement really never ends. What you want to build in your practice is not hazard, occasional quality improvement, but really regular discipline, continuous quality improvement. That becomes a part of your culture versus a project. So now to preparing us for our in-person training curriculum. So as you can see here, when we do our 3-day training in Denver, focus on these quality improvement overview steps. And the tools are in these orders for a reason, and you'll see that both today and in the in-person training and the follow-up. Essentially, the first focus is how do you know where area of focus is? So you can be thinking about patient satisfaction, a chronic disease measure, a prevention measure, a pediatric measure, a cost measure. But really, we're coming into the day of training here a little bit. What we're going to be thinking about is what does our practice really need to focus on? During this webinar, through the global aim statement. A global aim statement is essential for a team. It defines what is our goal, what period of time, and it defines where your process begins and ends. And I'll say more about that in a minute. But first mistakes I made when I was new to quality improvement was that I wouldn't have teams set global aims. We'd be working on improvements and changes. And after several months, we'd look back and say, well, did we reach our goal? And sure enough, we didn't know because we didn't set it from the beginning. So we will be talking about that here in just a moment. So we start with current state process mapping. So whatever our issue is and however we've defined our process start and end in the global aim statement is where we start. And it's really, really essential to focus on the current state process mapping and jump to how to fix it. And all of us as healthcare providers and healers want to fix things. But it's really important to start with the current state process map. Things operating today. This formal leadership has to be very careful how to respond to a current state process mapping, because they may come in thinking, well, we have policies, we have procedures, everyone's doing something in a certain way. But it actually probably isn't happening the way that we anticipate. So this is, we really want everyone's honest feedback about what the current state is. State map. And to do that current state map, we're going to start seeing where there's gaps and duplications and where we can improve it. And so we start thinking about how do we map out our future state. And so this is where we sort of start creating our ideal future state. We'll be doing that together in the in-person training. And then before we roll out our new process and procedures, we do a gap analysis. So that will prevent us from getting to the ideal state that aren't captured in a process map. And again, we'll be doing that together in the in-person training. And finally, after this comprehensive process, we say, how do we now do PDF-based cycle? So how do we set these smaller aims and start working on tests of change? So for about the global aim statement. So a global aim statement is a worksheet that you will receive when you email Sarah LaFave to attend the training. You'll receive this webinar recording, you'll receive the agenda template and this global aim statement template. And what I'd like to charge you to do between today when you're watching this and the in-person training, and especially if you're bringing a team, is think about what do we want to work on. We'll be at the beginning of the training day, but you'll get a superstar if you come prepared with your team. Off the top here is where we define what we want to aim to improve. So we aim to improve what? When we fill out that top line, we want to set a SMART goal. And by SMART goal, we want it to be specific. We know what we're going to do and how often. We will be measurable, so we actually need data to say where did we start and how we know we've improved it. We will be attainable, so we know we can do it. Often when teams are new to quality improvement, they either set really low goals or really high goals. We definitely do not want to set stretch goals that we can't achieve, or we will lose momentum of the team. And it takes your team some time to really think about and figure out what attainable goals are. And it's okay if you undershoot your goals or overshoot them at the beginning. You can make appropriate adjustments as you go on. And so with all the things we have going on right now, is this a high priority project? And that's really essential. I keep saying critical few, but what are the critical few things that we need to work on as a team to make our lives better, the lives of our patients, and meet our goals for our payer contract or for for our system. So what's realistic? And then limited. So by when will we do it? So let's go back to the global aid statement. So across the top, and I know I'm totally making this up and it may not relate to you, so I'm just giving you an example. Say we are wanting to improve the patients with A1Cs over 9. So let's say right now we've done a baseline data collection and our rate of patients with A1C over 9 is 30%. So we aim to improve that our patient population of diabetics with A1Cs over 9 will go from 30% to 20% over the next 9 months. So again, specific, data involved, it's time limited, and we think it's realistic and attainable to do that. You want to say in. So in, are you doing it at a specific site? And we highly recommend that you change processes small and roll them out from there so you learn all the lessons with a smaller group. So here you might be defining a site or defining a team. You might have multiple teams within a practice. You're going to start it in one team, so you don't have to define that here. If it's a small rural practice or you're just one big team in a practice, you might in our practice. The process begins with and the process ends with are tricky part of this global aid statement. So this is really going to define where your process map begins and ends. And often people can, when they're doing quality improvement, think, well, the process begins with walking through the door who has diabetes. But what that doesn't take into account is all those patients who may not be walking in your doors that have diabetes. And that's why empanelment, the first step, is so crucial. So defining your active and inactive patients, getting your patient panel cleaned up, and making sure your panels are equalized across your providers is an essential part. Once you're able to do that, you can have confidence in your data and say, well, our process actually begins with the identification of all of our active patients with diabetes. Get into practice transformation, you realize that you need to be thinking about your practice population as a whole, not just those who are walking through your door. It begins with the addition of our patient population with diabetes. Will the process end for each of your practices? In case the process may end with, let me tell you what it can't end with. It can't end with 100% of your practices having A1Cs under 9. Even though really as healers and healthcare providers, we want to do everything we can to support our patients. We know, look at the patient activation statistics. There are just patients with multiple barriers. Look at the studies on childhood trauma and other things that impact lifelong health. There's just going to be patients that cannot be engaged in a certain period of time. The process needs to really, you need to be thinking about where it ends, knowing that your practice has done everything you can to engage your patient. So the process may end with all of your patients with A1Cs over 9 having a personal care plan, and may end with a certain number of outreach to all your patients to get them in with A1Cs over 9. But typically, it needs to be where you're satisfied with everything that you've done. These two items are really important for team engagement. As many of you may be by a health system or you may be responding to payer contracts, often it can feel like everything's coming from outside of your team to tell you what to do. And the last two pieces are really important to engage your team. So working on the process, we expect what? So what are the benefits? And you need to come up with those, not necessarily formal leadership. You can participate as an equal team member, but learn from your team, why is it important to work on disease care for patients? So let them list the benefits. Think about working on this now. Why is this important now? Partially because of payment, and you want to be financially sustainable, and that's okay. But what else is it important, why is it imperative that patients with diabetes have outcomes? So this is really an engagement where the team starts taking ownership of what you want to work on versus it feeling like it's coming from the system or the health plan or formal leadership. So an item between when watching this webinar and the in-person training is to be about, if I'm bringing on bringing my team to the training, what are we going to work on during the training? And we will be having you fill this out at your table or your team If you fill out ahead and facilitate it with your team, you'll get an extra gold star. I just want to tell you a couple of leftover things here, which I know Sarah mentioned, and you're aware that there are two different activities going on in the state. One, practice transformation, and there's 4 practice transformation organizations that actually help you with practice transformation. Interested in that, you can contact Sarah for more information. And there's this training program. And they're very nice and complement to each other because practice transformation gives you that in-practice consultation, and this training program gives you the skills and tools necessary to do it in a sustainable way, both in your practice transformation and beyond. It provides a nice opportunity to get your team engaged, give them skill-based training they can't get elsewhere, and also help them understand the context and the why we're working on things. And I know I've mentioned, but I want to say again that you will receive this slide deck and the webinar, the agenda template and the global aim statement from Sarah once you sign up for the training program. And we do have you signed up and for you to attend all the modules. With that, we'll close the webinar, and we appreciate your attendance. Thank you.